So anyways, I want to start out by thanking Southern Alberta Council on Public Affairs for allowing me to speak to you, as we hope that in the coming months and as we draw near to a new election, both federally and provincially, that we put this issue at the forefront of Canadians who want to see this program come to fruition. I think this is one of the, an area that's known as the unfinished business of Medicare. This is not a new area of advocacy. We have been advocating for this for at least 2 decades now, or since the inception of our public health care system. The public health care system, initially, Tommy Douglas's vision included the first stage of us addressing affordability to some degree. And at that point, we made a pledge as Canadians that we would never, ever see a Canadian die because they can't afford health care. And we also made a pledge that no Canadian would ever have to go bankrupt because they can't afford health care. So for us, this is one of those areas that definitely needs the attention that it should have received a long time ago. But so for that purpose, what I'm going to do really, the overview of my presentation is that I want to tell you a little bit of who we are, and then why we're here, and why we need a national drug plan, and who should it cover, because I think that's the conversation that most people want to have, and what drugs it should cover, and how it should be funded. And then of course, what can you do to make sure that where we're politically at actually gets that extra push. So. There we go, my hero. Friends of Medicare, if you're not familiar with who we are, is a nonpartisan advocacy organization that has since 1979 promoted the protection and expansion of our public health care. Public health care that is enshrined in the values of equity, of access for all based on need and not ability to pay. And I think you're going to hear a lot of that. The principles of the Canada Health Act is a little bit of what guides the conversation around the implementation of a Pharmacare program. We use that as a guiding principle in the work that we have done to push a single-payer national Pharmacare program. And for us, this whole conversation is about equity, like I said, and the facts that medication should never be a luxury for only of those that can afford the prescribed medications. I think the universality of our program has a tendency to end as soon as you're given a prescription. And if you're fortunate enough to be able to have some type of coverage, then it's a different conversation. But we will explore all those problems and issues that come from that throughout my presentation. And one of the reasons why actually we are here right now is because these 3 fine men will actually be vying for your attention in the federal election. And what we're trying to do is actually talk about the political will to lead and talk about the political will to make the necessary changes that will need to be made to see this program actually be realized. Federally, we're going to be going into an election. Provincially, we're going to be going into an election. And it takes buy-in from both governments for us to be able to have a successful and a well-implemented Pharmacare program. Today, the Atlantic premiers all got together in their Atlantic premiers meeting, and they all put out a call to support Pharmacare, which is really good. You know, we want to see buy-in from the provinces, so we want to make sure that whoever leads the province in 2019, that we will also see that push for a national Pharmacare program when it comes to the time of Western premiers to actually take action and support a program. So why are we here? Canada is the only country with a single-payer universal health system that does not cover prescription drugs. Like I said before, the universality of our healthcare ends as soon as you get a prescription. So this translates into 1 of 10 Canadians who are unable to afford prescription medication. And that's the one. We, across Canada, drug coverage is a patchwork of drug programs. We have over 100,000 across the country. These are only the public ones, right? With provinces offering some coverage for low income, those with disabilities or seniors, while others have access to private insurance, such as through an employer. While we know that public plans can help some low-income Canadians, some only cover very expensive drugs, meaning that patients are left to pay lower cost out of pocket, or which is impossible for some. So where you live, your age, where you work, determine what is covered. And also whether or not you have some kind of chronic disease like cancer, right? So this patchwork of coverage has resulted in inequalities and inability for some people to buy medication when it's prescribed to them. Andre Picard, in the Globe and Mail, pointed out that about 20,000 out-of-pocket hospital cancer drug treatment would be free for patients in Nunavut. It would cost, the same drug would cost about $3,000 in BC, and the full cost in PEI. So it's inequality in terms of portability, which again is one of the principles of our Canada Health Act. This goes against the principles of our system, which would treat us equally regardless of where we live, or the expectation would be. So what happens is that sometimes we have people traveling to other provinces where their medication is actually covered. And it's not, it kind of takes away from the ability to say that our Canadian healthcare system is equal for all of us, no matter where we live. As I mentioned before, drug coverage is a patchwork of programs across the country, with provinces offering certainly a variety of drug plans, and Alberta is no exception to this patchwork of programs in the way that we provide drugs and benefits to Albertans. We currently have 23 drug and supplementary benefit plans. So again, your age, if you're a senior, if you're not a senior, your income, where you work, and where you live. So if you are living in a long-term care facility, medications are covered, but if you're living in a DSL-4, which is a little bit lower, you have to pay for your medication. We do have a plan that actually covers some of the seniors with a $25 cap, but if you're on one or more medications, that can add up really quick, and a lot of people are not in a position with a fixed income to kind of continue to pay that. Our current drug plans, the 23 drug plans, cover 20% of the population. We cover 900,000 Albertans out of the 4 million people in this province. The rest, like I said, if you're lucky enough to have a work plan, you're on the other side, but if you're not, then you're looking at making some difficult choices sometimes. Even with that small percentage of those in the public system, drugs and supplementary benefits are among the highest expenditures of our healthcare budget. And for years now, we have seen an approximately 10% increase in the cost of drugs. So that's what makes these plans really expensive, is the fact that the cost of drugs continues to go up, regardless of whether or not the provincial government tries to buy generic drugs, which is what the direction that they have been taking for a long time. And we have seen some reduction in the cost. I think the government had given the mandate of decreasing some of this budget to 2 or 3% last year. Obviously, they weren't able to do that because that would have meant again meant that a lot of the drugs would have been not covered or the cost passed down to the people that are actually accessing those drugs. And so we continue to see an increase. And we also see an increase in those that are eligible for these plans. For example, in 2013 and continuously, we always see an increase in the amount of seniors that are accessing seniors benefits. In 2013, we saw 4%, and every year it continues to go up as our population ages. The downturn in the economy also mirrors the increases in these drug plans and the amount of money we're paying. Low-income plans, for example, mirror unemployment rate. In 2018, 6.7% is what what we saw as our unemployment rate, and it was down from 7.8 in 2017. And normally, those plans usually mirror the increase of people seeking public help. Again, the health expenditures is there. It's kind of hard to see, but the drugs is the third highest little pie there out of the $20.8 billion. And again, it's impacted by how many people we are covering in that particular year. And Canadians pay the second highest price in the world for brand name pharmaceutical medicines and the highest for generic medicines. In Alberta, biologics drugs are costly, and we've seen a significant increase, 17% since 2015, and a steady growth again of at least 10% every year. So what does that mean to you, to me, and our families? It means actually that 1 in 5 households in Alberta experience financial barriers in getting their prescribed medication. And while many workers in Alberta enjoy some kind of workplace benefit package with some prescription drug coverage, 1/3 of Alberta's workers don't have health benefits. And one must also remember that benefit plans are part of negotiations. So if you've ever been in a situation where you need to bargain your benefits, usually some people will not take a wage increase, but they will get better benefit package out of it. So technically, we're paying for that increase anyways through the loss of wages. So in terms of lower wages. Just the other night we were talking to an owner of a manufacturing company, and he was talking about the fact that because of the increase in prescription drug costs, he said that they had gone so high that he took away his employees' vision benefits to recoup some of that rising drug plan costs. So work plans are not something that we can rely on. In terms of bargaining, we lose it through our wages, but you can also lose your job or change jobs into a place where you no longer have benefits. Sometimes you get a divorce or separate from a partner who had the benefits, and all of a sudden you're faced with no benefits at all. So work plans are not something that we can rely on. And then there's what we know in Alberta, precarious employment and part-time employment. In Edmonton alone, before the October of 2018, over 100,000 people were earning $15 per hour or less when the minimum wage increase came in. And the majority of them were older than 25 years old. So we're not talking about the teens that are still covered under their parents' program if they have one. And this work is often precarious and without benefits. Here in Alberta, 3/4 of Alberta's 390,000 and some part-time workers didn't have prescription drug coverage. And in 2015, there were 375,000 self-employed workers in Alberta without employer-based health benefit coverage. And our seniors coverage, like I said before, requires an out-of-pocket co-payments for up to $25 per prescription. And this plan is often always talked about because we I don't know if you recalled a couple of years ago, actually in about 2014, 2013, we actually had to occupy the minister's office, Fred Horns, when he was the minister, because of the implied changes that they were going to be doing to the seniors' benefit plan at that time, leaving a lot of seniors without the ability to afford their medications. For us, barriers to access not only means people don't get the medication they need to live a healthy life, but our health system becomes burdened in emergency responses in hospitals for those who are sick with avoidable illnesses. I'm hoping that you'll be able to see. In May of 2018, the Canadian Federation of Nurses came out with this report. And apart from unquantifiable value of human life, the cost-related non-adherence to prescribed medication is an important public health consideration affecting health outcomes and overall healthcare costs. For me, this study is what should just make people understand why it is that we need a national Pharmacare program. Last year, 420 Canadians died because they couldn't afford their diabetic medication. You know, we have up to 70,000 older Canadians, 55 plus, who suffer avoidable deterioration in their health status every year because they can't afford their medications. We have up to 12,000 Canadians with cardiovascular disease, age 40 plus, that require overnight hospitalization because they haven't taken their medication. 370 to 640,000 premature deaths in the Canadians with, if I could read it, with heart disease every year. So for us, is a human cost that can't be recouped. You know, I think when we talk about a Pharmacare program, conversation should be guided with the discussion of, instead of who's going to pay for it, we should be asking ourselves who's going to benefit from it. And definitely, we should not be looking for excuses for us to not have this program in place. Any human life is definitely not something that we could put a price on. So why do we need a national drug plan, apart from all the reasons that I've already given you? A universal prescription drug plan is part of a broad-based poverty strategy when you're looking at the social determinants of health that can help those people in need. People should not have to choose between groceries and the medications they need. In Alberta, to give you an example, due to financial and knowledge barriers, many Albertan seniors with or at risk of cardiovascular disease do not receive the recommended preventative medications and are therefore at a much higher risk of heart attacks, strokes, and other complications. Recent surveys have suggested that some Albertans, seniors with lower income, struggle with paying insurance co-payments for their prescriptions, causing them to stop these important therapies sometimes. And for instance, we have seen up to 50% of Albertans at high risk of heart disease who do not receive the recommended cholesterol-lowering drugs only because they can't afford it. Cardiovascular events such as heart attacks and stroke, along with chronic disease, can lead to cardiovascular events such as diabetes, result in significant morbidity and mortality, costing the Canadian healthcare system over 93 billion per year. Our system is intentionally designed to prioritize drug companies' profits, and that's one thing that it does very well. One of the stated reasons was that we were paying pharmaceutical companies to have so much control of what's in the market or not, is the fact that they were supposed to allow more research and development of drugs. But that aspect has been a failure over and over again. We watched research and development in relation to sales decline from 11.5 in 1999 to about only 4.5 in 2013, and that number hasn't increased very much, while companies' profits continue to rise. And their profits give them even greater clout to influence the system. We currently allow drug companies to fund our approval process because they pay half. So they just have to prove that their drugs is more effective than a placebo for them to actually be able to bring in a new drug. Also, drug makers say that the fault lies with the insurers, that shift costs to consumers more for drugs than they do in hospital and Medicare. If you find anybody who's not in support of the Pharmacare program, it usually right now is the insurance companies and the pharmaceutical companies. Go figure. But it's a funny conversation that's being had at the national level. There was a paper that was actually put out by the Innovative Medicines, which represents the pharmaceutical companies who blame the insurance company for upping their premiums based on faulty predictions of drug increases. And then the insurance company saying, well, you guys are the ones that provide those numbers, so it's really not our fault. But the insurance companies are really wanting to be part of the conversation right now and see what their new role could be in a national Pharmacare program. We have a very clear direction of where the insurance company's role could not be in the National Pharmacare program. But again, those are discussions that are currently being had. So we're going to talk about who should cover it. Who should actually, that should say who should be covered, not who should, well, who should it cover? It's the same thing. What we're saying is that all residents of Canada should be covered by a national public drug plan. And this coverage should be portable from one part of the country to another. Again, we don't want Canadians to have to move to another province so that they could have whatever required medication that they need covered in the province that they've decided to move in. And there should also be no co-pays or deductibles, since even at the modest levels, they have been shown to prevent patients from receiving the medication they need. There was a research study that was done by the Canadian Labour Congress that indicated even co-payments of $2 was sometimes cost prohibiting for people to be able to get the medication they need. And I know that it sounds really low, but there's some people that basically can't afford $2, right? And that's a reality for many Canadians. We don't require co-payments for visits to the hospital or doctors or treatment at the hospital. So our stance is, why should we have to pay for co-payments when we need sometimes life-saving medication? Oh my goodness, I thought I was doing really well. Again, it has long been a central tenet of our healthcare system that good health should not be based on person's ability to pay, but basically, should also be applied to prescription medications. What drugs should be covered? And again, what we want to do is actually see a program that's actually not a race to the bottom. We want to see a formulary that's safe, that's evidence-based, and that meets the needs of Canadians. We don't want to see people lose their benefits, because a lot of people will say, well, I'm going to lose my perfectly good medication plan, and I don't want, and the public plan is not going to be able to cover that. We want to make sure that the formulary is actually meets the people's needs, and we have an opportunity to make that formulary a right formulary, like I said, that is based on evidence, that is safe, that the drugs that are going to be on the formulary are effective, and that will meet, like I said, even those people that have rare diseases. It should be reviewed for inclusion, and this is a really important part of who should be covered. These drugs should be reviewed for inclusion on the formulary by an independent body of medical experts and researchers with no connections, commercial or otherwise, to the interests of pharmaceutical companies. And all drugs on the formulary, like I said, should be safe and effective. And this review process needs to be transparent, and doctors and medical researchers have access to research information necessary to adequately assess drugs. We want a formulary, like I said, that's evidence-based. And we definitely want to see the federal government and provincial governments having a say in what is on there. And how should the plan be financed? That's another huge question that we always get asked. We're saying that it should be financed in the same manner that hospitals and physicians are currently financed, coming from general revenue, and that the federal government needs to step up to their federal responsibility in terms of ensuring that the funding that they commit to will be there regardless of the economy and regardless of what changes in the government are. We, initially when Medicare came in, the federal government was paying 50%, and that has changed significantly. We're down to 19%, and a lot of times the provinces have been left to hold the bag. We want to make sure that this plan is actually one that will have funding that's sustainable, and that where the federal government will definitely meet their obligation, their federal obligation, and we don't want to see any type of unfair taxation. There was some talk about doing a Pharmacare tax. That would be an unfair tax for people to have. There's all kinds of conversations happening right now about how we would fund this. It would take about $16.4 billion as the initial investment to fund this program. Currently, we're paying 20-point-something billion dollars. But the savings that we would see, according to the parliamentary budget officer who came down with this report, it would be about $7.1 billion in household expenditures right now, and $9-point-something billion, a little bit over $9 billion just from other program expenditures. So it would be a significant saving down the road. The initial investment, though, would be about $16.4 billion. It would mean, at the end of the days, when all the numbers are crunched, according to the parliamentary budget officers, that we would only see an increase of about 2% more new spending by the federal government to implement this program, which, when you look at it, is basically a drop in the bucket when we're talking about billions of dollars. So we can afford national Pharmacare, and this is something that we will be pushing for a long time. So part of our work, very quickly, we have actually been working with our national partners. We're waiting after all the stuff that we have actually been engaged in to make sure that this is on the agenda in the upcoming elections. The report that we're waiting for is the advisory council that was set up last year by the Liberal government, led by Dr. Hoskins, who used to be the Minister of Health in Ontario, and they will be tabling a report that's supposed to be the blueprint to the implementation of a Pharmacare program. We know exactly what we want to see in that blueprint, and our work is basically ensuring that we take this to the end line, that we will have a drug plan that has all the asks that I have talked about during this presentation, and we're asking people to actually meet with their MPs, to talk to their politicians, provincial and federal, and make sure that they stand by something that will benefit all Canadians. We want to get to the point where people ask, what was life before Pharmacare came in? And that's our ultimate goal. So thank you so much for listening before I...